class, let's talk about how antibiotics and specifically other antimicrobials, so the antivirals, the anti-parasitic agents, the antifungal agents, all work to help keep us happy, healthy, and safe. Most of this chapter we're going to focus on antibiotics, though, because that's the most established field of these categories of chemicals. So let's first talk about some basic principles of antimicrobial theory. Modern drugs were introduced to control infection back in the 1930s. This introduced a medical revolution with the discovery of penicillin. Antimicrobial drugs have reduced the incidence of very specific infections, but have not eradicated specific infectious diseases, and probably never will, particularly as our infectious diseases right now are in an arms race with us. We come up with a new drug, they come up with a new resistance, new drug, new resistance, so on and so forth. It's kind of like the Cold War that was between the United States and the Soviet Union. Today, most healthcare professionals are worried that we're really, really close to a post-antibiotic era, that we're going to approach a time when most microbes are resistant to most of our antibiotic drugs, and the drugs that we do have will no longer be very effective. So if we give somebody an antimicrobial chemotherapy, and this term right here, chemotherapy, is a loaded term. When most people see this term chemotherapy, they think of cancer treatments. But technically, all it means is that we're using a chemical for some therapeutic action. So we're using an antimicrobial chemical for therapeutic action. That's an antimicrobial chemotherapeutic agent. When we give antimicrobial chemotherapy, we're trying to have a drug be given to the infected person, some kind of a chemical to the infected person that will destroy the pathogen cells, but not destroy the host cell. So if we could find something in the microbe that's only present in the microbe, that's not present in human beings, whatever that something is, it's going to be a really good target for the chemicals, for our antimicrobial therapies. So our drug needs to be easy to administer. It needs to be able to get the infectious agent anywhere in the body. That is a tall order, particularly when you start dealing with the hydrophobic, hydrophilic natures of the aqueous environment and then the barrier membranes in our bodies. This drug needs to be absolutely toxic to the infectious agent and non-toxic to the host. In other words, it should not have any side effects, and it should stay in the body as long as we need it to, but it should be easy to get out of the body when we no longer want it in the body. So kind of like when we were talking about chemical disinfectants, our antimicrobial chemotherapeutic options or ideals can never be completely met. No drug meets all the characteristics of the ideal drug. And of course we want it to be cheap, we don't want it to be expensive, we want it to be microbial-cidal, not microbial-static, so on and so forth. These are what we shoot for. We've never arrived at the ideal antimicrobial drug, and no drug really has come close to approaching this ideal either. So as we look at the terminology behind chemotherapy, this term chemotherapy, we have the chemotherapeutic drugs, so just the chemical that we give to make ourselves feel better. If you hear the term prophylaxis is a preventative dose of the drug right before the person's probably going to be at risk. For example, before I run a half marathon, I pop some prophylactic ibuprofen because I'm pretty sure I'm going to feel terrible the next day or later that day, so why not get a head start on my therapy regimen and take some ibuprofen right now? I have this short-term preventative treatments with drugs. We can have antimicrobial chemotherapy. This is going to be the use of a drug to control infection. An antimicrobial is a drug that kills a microbe. Antibiotics kill bacteria. Semi-synthetic drugs are drugs that can be modified in the bacteria after being isolated from a natural source. So they started out as natural and then had an artificial flare or twist at the end. Fully synthetic drugs are going to be made completely in a laboratory setting via component chemical reactions. So our semi-synthetic drugs can be an in vivo source, or drugs from an in vivo source. So we will design genetically engineer microbes to produce the drug for us. Synthetic drugs, on the other hand, are going to be an in vitro source. They are made without genetically engineered microbes. Instead, these full synthetic drugs are made in test tube reactions. We can have narrow spectrum and broad spectrum drugs. Narrow spectrum drugs are very targeted. Broad spectrum antimicrobials are going to work out against a wide variety of microbes. Antibiotics are one of the single most common metabolic products of aerobic bacteria and fungi. So aerobic bacteria and fungi are already making antibiotics. And our antibiotics that we have right now, generally speaking, started out as isolated from a natural source, an aerobic bacterium or fungi. This is because our aerobic bacteria and fungi are constantly competing with each other, and they want to kill each other off. They want to kill the competition so they can have more of the resources in their habitat. There are a lot of bacteria in the genre Streptomyces and Bacilli that we derive our antimicrobials from, and molds in the genre Penicillium and Cephalosporium we can also derive antimicrobials from, or have derived antimicrobials from. Before we can actually start antimicrobial therapy, we need to know a couple things though. We first need to know what is making us sick. If it's a bacteria or a virus or a protozoa, that's going to have a huge impact on what chemotherapeutic regimen is prescribed. An antibiotic works for bacteria, but it's terrible for viruses. You want to give an antiviral with a viral infection. The degree of the microorganism's susceptibility or sensitivity to the drug also is going to influence your choice. Generally speaking, if you have a microbe that is not antibiotic resistant, you're going to give the low-level antibiotics that have been around for a long time. The high-level antibiotics, the high-octane antibiotics that are the newer ones, are typically only reserved for the situations where a drug or a microbe already has resistance to the older known antibiotics. And then finally, the overall medical condition of the patient is important. Is it an infant child? Is it a pregnant nursing woman? Is it elderly? Is it a healthy adult? Or is the patient a healthy adult? These conditions will influence your drug choice. Do they have 2 functioning kidneys? Do they have half a liver? Those are also really important things to consider. So, we need to identify the infectious agents. This identification of the infectious agent should happen as soon as possible. It should ideally occur before the drugs are given, and before the numbers are reduced. By identifying the infectious agents before the drug therapy has occurred, we are more likely to get a positive ID. Generally speaking, we get direct examination of samples. This is going to be involve taking urine samples, sputum samples, blood samples that can be that we can send to the lab for detection. Doctors can also begin therapy on the basis of immediate findings or informed guesses. So in other words, you tell the physician, what are your symptoms, what are you feeling, what risky behaviors have you been doing, and then the doctor can make an educated guess and say, oh, this is probably this disease. I'm going to be proactive and start this regimen before the lab results come back. And then finally, epidemiological statistics may potentially be required to help us identify what is going on. For example, if you spent a lot of time in Africa recently, that may potentially influence what diseases you may have been exposed to compared to if you spent lots and lots of time in northern Canada. We always need to test the following organisms for drug susceptibility, particularly the Staphylococci, Neuraceae, and Streptococci, and the gram-negative intestinal bacteria. These are bacterial genera that have already demonstrated antibiotic resistance to a wide variety of antibiotics, and for an effective regimen routine, we need to know which antibiotics these particular strains of bacteria that are in the patient are susceptible to. Testing for fungal or protozoal infections is difficult and unnecessary. It takes a long time, and generally speaking, we don't have many options for our fungal or protozoal treatments. So, regardless of what the test results are, we're probably still going to have the same regimen prescribed. Testing is also unnecessary for organisms known to be susceptible to penicillin G, unless the patient is allergic. Penicillin G is a wide-acting drug, and there's not a lot of susceptibility for penicillin G. The problem with penicillin G is it doesn't affect all microbes. It doesn't affect all bacteria. One main reason not to give penicillin G, though, is some patients are allergic to penicillin drug derivatives. To test for drug susceptibility, we use a method known as the Kirby-Bauer technique. I informally call this the zone of inhibition method because we are going to measure zones of inhibition. So for the Kirby-Bauer technique, first you take a nutrient agar plate and you completely cover it with the bacterium in question. And you'll have a continuous lawn of bacteria growing. And at the same time that you inoculate the plate, you're also going to take a small punched out paper disc that has a bunch of antibiotics in it. And you'll put it on the disc. And then the antibiotics slowly diffuse away from the paper disc and kill the bacteria. Closer to the paper disc, there's higher concentrations of antibiotics, so we're more likely to kill the bacteria. Farther away from paper disc, the concentration of antibiotic is lower and we're less likely to kill the bacteria. Let's skip ahead here. So here we can see in the upper corner, we can see that paper disc, and the antibiotics have diffused away from the paper disc and killed the bacteria that we inoculated on our nutrient agar plate. Here we go. So that zone of no growth where the antibiotics have killed off the bacteria is known as the zone of inhibition. And we measure that zone of inhibition and use it to determine whether or not our particular strain of bacteria is resistant or susceptible to our antibiotic. We compare our growth on our Petri plate to known standards. So we have known controls that we compare them to. An antibiogram is going to provide the data that we need for this drug selection. An antibiogram is on the next page. I'll show it to you. This method is typically less effective for anaerobic or fastidious or slow-growing bacteria. Why? Because we want quick results, and these fastidious or picky or slow-growing or anaerobic bacteria are more finicky to work with, more difficult to work with. Here is our antibiogram. So it provides our data. So if I have a zone of inhibition for bactricin, or let's go with one I can pronounce easily here. Let's go with vancomycin. Vancomycin is an easy to say one. So if I put my bacteria on my Petri plate, and the zone of inhibition is larger than 12 millimeters, then I would say that my bacterial species is susceptible for vancomycin. If my zone of inhibition was less than 9 millimeters, I would say my bacterial species was resistant to vancomycin. So even if the bacteria is resistant to the drug, high enough concentrations of the drug will eventually kill the bacteria. The problem is, those really high concentrations of drugs generally kill the patients too. And then there's an intermediate space. So let's say I had a zone of inhibition of 10. And I'm working with vancomycin. Since 10 is in between the minimum cutoff for resistance and the minimum or maximum cutoff for resistance and the minimum cutoff for susceptibility, 10 and 11 are in between here. If I had a zone of inhibition of 10 or 11, I would say that there's an intermediate resistance. So let's look at some example results. Let's say for Staphylococcus aureus, for a specific strain of Staphylococcus aureus isolated from a patient, there was a zone of inhibition of 20 centimeters for chloramphenicol. 20 millimeters is greater than 18, so we would say it's susceptible. If we look for Staphylococcus aureus and we found that it had a zone of inhibition of 15 millimeters for erythromycin, 15 millimeters is between 13 and 18, so we would say intermediate. If we look over here, Staphylococcus aureus had a zone of inhibition of 10 millimeters for penicillin G. If the zone of inhibition is less than 20 millimeters, we say that that strain of bacteria, the Staphylococcus aureus, is resistant to penicillin G. So because 10 is less than 20, we would say R for resistance. That's how we would evaluate it. So here are some dummy results. You would look at a Petri plate and you would measure your results. We'd have different antibiotic discs on different regions. Here you would measure the zone of inhibition. Our zone of inhibition in this situation, we're measuring the radius. Let me double check here. Yes, the radius of our zones of inhibition. This radius, the diameter of our zones of inhibition. So I look at this diameter. The diameter is 10, 20, about 27.5 millimeters. 27.5 millimeters is greater than the 22 for the cutoff for that drug. So you'd say that it's S for susceptible. This bacterium is susceptible to enthroflaxin. But if we look over here for oxytetracycline, if the zone of inhibition is less than 17 millimeters for that diameter, then we will say that the bacterium is resistant, and we don't actually have the ruler over it on the screen, but I can promise you that this is definitely going to be less than 17 millimeters. It's definitely less than that based off the ruler over here. So we can have different zones of inhibition for different antibiotics. You would hold the ruler up to the Petri plate, measure the diameter, and then look at your data table and go, okay, for this drug, the bacteria isolated is susceptible, resistant, or intermediate. And then you would choose, when you would prescribe an antibiotic, you would choose antibiotics that that particular bacteria was susceptible to. We can also use dilution tests for drug susceptibility. A dilution test is different from the Kirby-Bauer technique. It's more sensitive and more quantitative than the Kirby-Bauer technique. The antimicrobial drug is going to be diluted through a series of serial dilutions in test tubes that contain nutrient broth. Each tube is then going to be inoculated with the same amount of our pure culture, or our bacterium that we've isolated in most situations. And we're looking for the minimum inhibitory concentration, the MIC, the MIC. This is the smallest concentration of antimicrobial of the drug that visibly will inhibit the growth. How do we measure if the growth is visibly inhibited or not? We typically have a pH indicator that will change color based off of the metabolic byproducts of the bacterium. This is very useful for determining the effective dosage size and comparing other drugs against each other. So here we can have our different tubes full of nutrient broth. One has absolutely no antibiotics in it, and then each tube has a slight, as we move down the line here, has a doubling of the concentration of antibiotic in it. And then we put the same amount of bacteria in each tube, and we record the kind of antibiotic, and we also have increasing concentrations as we head from left to right, and we can see once we go from purple to blue, we have reached the minimal inhibitory concentration. So I can see here, by looking at the colors that the wells have turned on my micro well plate, that for A and B, and I don't remember what the antibiotic A and B is the abbreviation for, that we have a lower minimum inhibitory concentration than we do for FLUC. And I don't remember what FLUC stands for in terms of antibiotic abbreviations, but this FLUC has a much longer row of pink on it. It requires a much higher concentration of that particular antibiotic to kill off the bacterium, or to prevent bacterium growth. We typically are going to use the in vitro activity of the drug is always not be the same as the in vivo effect. In other words, the activity of the drug in a glass test tube or in glassware in the laboratory is typically not going to be the same as in the organism. In the organism, there are many more chemical reactions, many more enzymes, many more side reactions that we don't account for when we do the test in a test tube. Oftentimes, our failure of antimicrobial treatment is due to the inability of the drug to get to the part of the body where we need it to be. There's the blood-brain barrier, there's joint capsules, there's the epithelial membranes of our skin that can prevent drug penetration to the correct part of our body. Or we can have a resistant microbe that's not going to be susceptible to that particular drug that we've prescribed, or we can have a mixed infection. Sometimes during these mixed infections, we have resistant drug microbes and non-resistant microbes in these mixed infections that are tough to treat. So we need to identify the minimal inhibitory concentration, and we also need, another thing to consider is the therapeutic index of the drug. The therapeutic index is a ratio. It's a calculation where we take the dose of the drug that is toxic to human beings and compare it to the minimum effective therapeutic dose. Generally speaking, we want a high therapeutic index. The lower the index, the more dangerous it is for the human being. The higher the therapeutic index, the safer it is for the human being. So a therapeutic index of 1.1 is pretty dang risky. A therapeutic index of 10 is a much safer choice. The highest therapeutic index will give us the widest margin of safety. So the higher, the better. When a physician is going to prescribe an antibiotic, oftentimes the physician will need to take a careful history before prescribing the antibiotics. Pre-existing conditions are going to be enormous. Does the patient have both of their kidneys? Does the patient have other medications that they're taking? Does the patient have some kind of lifestyle habit or other disease that will influence the activity of the drug? Does the patient have a known allergy to the drug? Is the patient really young? Is the patient elderly? Is the patient pregnant? Is the patient going to take the drugs, other drugs that may potentially have side reactions with each other? For example, taking a barbiturate at the same time of that you take a sedative is a very bad idea. Mixing medications and alcohol, for example, is a terrible thing to do. Does the patient have any kind of genomic or metabolic abnormality? Some patients have mutations for particular metabolic pathways and cannot metabolize particular drug compounds? Or how is the drug going to be administered to the patient? Or what is the cost of the drug? Or where's the infection on the patient? These are all things that need to be considered by the physician when determining the best course of action. So let's talk about a hypothetical case here. We have two of them for. And this is, for the nursing students here, they're just going to be right up their alley. For those of you that aren't planning on being nurses, bear with me. This is a real-life example we could talk about here. So let's say we have an elderly alcoholic patient that has pneumonia caused by a Klebsiella infection. This infection has been complicated by the fact that this alcoholic patient has, diminished liver and kidney function. Go figure. So they require peritoneal drug administration, and they have a history of allergy to penicillins. Well, right off the bat, we would know as we look at this patient that we would not want to administer any kind of a drug that is a penicillin-based drug to this patient because they have that allergy to penicillins. We also know, based off this patient history, that we are going to want to administer a drug that has the highest possible therapeutic index, more so that in most situations, because this is a compromised patient. They have poor liver and kidney function, so the toxicity of the drug being administered is going to be increased compared to a healthy patient with a healthy liver and a healthy kidney function. So the therapeutic index becomes quite important when you're dealing with these compromised patients. We can also look at a cancer patient with a systemic Candida infection. This is a systemic yeast infection in their body. An antibiotic is not going to be effective at all for this cancer patient with a severe Candida infection because antibiotics are not antifungals. Candida or yeast is a fungus, so we'll need to administer an antifungal to this patient. Also, since this is a cancer patient, they probably are going to be on some kind of chemotherapeutic drug that is going to cause their immune system to be compromised. So in addition to being immunocompromised, we also need to prescribe an antifungal instead of an antibiotic. Even if the physician has all the information, the final choice of drug is never easy or straightforward. So just based off of the information we have here for our elderly alcoholic patient, there still are some viable options that we can prescribe because we have quite a few different options here. But what's the best one? It depends on the specific strain of bacteria and the zones of inhibition that have been measured. There are many factors that need to be taken into account. So, let's do a concept check class. Which of the following antibiotics would be the safest choice for a patient who has no exceptional medical history? So let's say a 20-year-old adult male with nothing weird going on at all. Would we want it to have a zone of inhibition of 30 millimeters and a therapeutic index of 1.2, or a zone of inhibition of 20 millimeters and a therapeutic index of 12? So, we have relatively large zones of inhibition, and then we have a small therapeutic index and a large therapeutic index. Do you want to go with drug A or drug B? Pause the video and get me an answer. The correct answer is drug B. If it has a very high therapeutic index, a therapeutic index of 12 is quite high, 1.2 is quite low, that's pretty risky, and a zone of inhibition means that regardless of the drug that we're working with, a zone of inhibition of 20 millimeters means that in almost every situation, that drug or that microbe is going to be susceptible to that drug. So, absolutely, drug B is hands down the best choice. It's probably going to be susceptible, or the microbe's probably going to be susceptible to it, and the patient is probably not going to have too many bad side effects from that drug because of the high therapeutic index ratio. If you have any questions about this topic, please post them on the discussion board or shoot me an email. Happy studies!